Well, first of all, thank you for the invitation for ISCVS and myself to participate in ICARUS. It's a real privilege. I'm going to talk today about some complications from treating the SVC occlusion. I've been doing this for a long time and had very few complications, but how the mighty can be humbled. And I thought I would give you the benefit of the experience of two complications that we fairly recently experienced. First was a 60-year-old woman, history of end-stage renal disease, now on PD, known SVC occlusion, who had significant symptoms from SVC syndrome. She'd had a previous failed attempt at recanalization. Really was not somebody who was fit to have her chest open, so we brought her back for another attempt, and we're going to use both femoral and jugular access in order to do this. Now let me set this up. Basically, we used from below. Unfortunately, I'm the one working from below using the Cook Triforce. We've used this for crossing many occlusions. It's got a wire, an inner cannula, basically in the outer support sheath, and it's been very useful. And I'm going to let this play here a little bit. Most of the focus is what's going on really from down below. And here you can see and advancing this inner catheter, and the inner catheter, went in a peculiar direction, went to the left of the patient. And so at that point in time, we took some dye and we injected, and you can see that when I injected this, and this really did not require a lot of force to do it, we get this nice picture basically of the pericardium basically filling up. So obviously, number one, we recognized that we had perforated into the pericardium. So at that point, we had not given any heparin. We immediately called for a transthoracic echo. The transthoracic echo was brought in, and at that point in time, it confirmed the presence of pericardial tamponade. Fortunately, we were immediately below the cath lab. We called the electrophysiologists who have experience in RV perforation. They immediately came down. We pulled in the TE. Could actually demonstrate in TE that there was a pericardial effusion. And this is my partner, Dr. Miguel Valderrabano from the EP world. Under ultrasound, gained access into this. Advanced, you can see the pericardiocentesis catheter wrapping around the pericardial space. Here you can see what it looks like when it's completed. And at that point in time, he aspirated, and we aspirated about 150 cc's of blood. Now, meantime, this patient did become unstable, never suffered a cardiac arrest, and as soon as we aspirated this from the pericardium, the patient completely stabilized. And again, we shot another cavogram. There was no evidence of extravasation into the pericardium at that point in time, and this patient actually did remarkably well. A patient would not have tolerated open pericardiotomy. We left this drain in overnight, and we pulled this out the following day. And so this is an example of, number one, perforation of the superior vena cava in its intrapericardial component, actively identifying that, having all the facilities ready to manage this, and having somebody who can come along and do pericardiocentesis immediately, and that patient did just fine. We pulled this drain out, as I say, 24 hours later. The drain was sewn in place. It was left with that big loop, as you can see, up in the pericardium, and was brought back. It was not actually brought back at all. It was discharged home. And so this was a near miss, if you like, in terms of what the outcome could have been. Here's case number two. Case number two, interesting scenario here. This is a 42-year-old, otherwise healthy woman. History of a lung wedge resection and a calcified mass. We really didn't know. This was not done at our institution. We don't really know what the etiology of that actually was. She'd been screened for fungal infection, histoplasmosis. Nothing was found. She was not hypercoagulable, and she was fairly symptomatic from this SVC occlusion, which I can show you here. And there was a big anterior branch which was coming from this. Once again, she had been treated at an outside hospital with an attempt to recanalize this and failed. We had a long discussion about whether she should undergo open superior vena cava reconstruction, which she was willing to, but wanted us to try and cross this basically one more time. So to try and optimize this, we actually did cone beam CT. We put a catheter above, catheter below, and injected while doing a 3D acquisition. We then reconstructed this and used fusion marks to show where the end of the occlusion was from superior. And you see there was a V-shaped end to this occlusion. There was a big anterior branch. And what this basically showed us was where to part the catheter in order to actually try and cross this lesion. And it really proved not to be that difficult to actually cross it. We crossed, relatively easily. And you'll see that I'm going to run this forward really a little bit in the interest of time. Once we got the wire going, we basically ran this forward. You can see it actually crossed into, we got it into the distal and the inferior vena cava below. At that point in time, we actually snared it from below and exteriorized the wire. So now we had a through and through wire, over which we actually put a sheath from above, and then we brought in the 10mm balloon. I'll let that run a little bit. This is exchanging out for a stiff wire that we've got here. That purple mark was the track of the occlusion. So what that allows you to do is to know very rapidly that you've actually gone through the occlusion along the anticipated track. The wire is exteriorized. We now brought in a 10mm balloon. After each of these dilations, we did a cavogram, so we went fairly rapidly from a 10mm balloon, then we went up to a 12mm balloon, and still didn't look quite as good as we would like it. And so we took it up to a 14mm balloon. And remember, so again, you still see a little bit of stenosis, so the rationale for going up and continuing to dilate this a little bit further. So next balloon kind of went in, and then the 14 balloon went up. Good sized balloon, not oversized for the cava. You can see it went up to 12mm. And now I'm going to run this backwards and forwards. Looks pretty good. Now, for those of you in the audience who are very observant, they should be looking at this. I thought what we were looking at was cardiac motion on the subtraction angiogram. In fact, we were so happy with this, we decided not to stent it primarily. You can certainly argue about the wisdom of that, and so we opted, we were heparinized at that point in time. We reversed the heparin, we pulled all the wires and catheters out, and the patient immediately bradycardied down and coded. That led basically to us calling in cardiac surgery. This lady, cut a long story short, this is the initial pericardicentesis, ended up with an emergency sternotomy and repair of the superior vena cava. Now, as you can probably imagine, we weren't going ahead and reconstruct the superior vena cava at that setting because she had been so unstable. The SVC was occluded when we restudied her, and we actually talked to her because that was clearly the time for SVC reconstruction if we were going to do it. We actually brought her back and reconstructed the superior vena cava about 3 days later. There are there are not many reports out there about the incidence of cardiac tamponade after superior vena caval stenting. But the message really here is that, and this is really interesting from Endovascular Today because it lists the thought process of when you're faced with this about how you're going to get out of it. Here's basically what I think about it. Number one, I first heard about this at Nick Hopkins' complications meeting. Prior to that, I really wasn't aware that you could get an pericardial rupture. Awareness and understanding this can happen is important. Early diagnosis, which can be done either by an angiogram, as we did here, or by echo. But the bottom line is if you dilate the superior vena cava and the pressure bottoms out, this is what's going on almost certainly. The mechanism is important. Perforation, we probably get away with pericardiocentesis. Rupture, you're not. Should you basically try to salvage this with a covered stent? That's a great question. The availability of echo is very helpful, and you got to be able to call a friend to come and bail you out of this. So hope this increases the awareness of this, and hopefully you're not faced with these problems, but if you are, these are the mechanisms to try and avoid what can be a mortality. Thank you.